Everybody, we're live. I'm one of your hosts, Jose Garcia, and I'm not the only host. I'm here with Anna Forsyth, um, former concert pianist, pharmacist, health economist, and now founder. I think it's not the first time you founded a company, Anna. And we're going to be talking about um, trust, oncology AI, and humans first. We're going to be talking about what that means. And we're letting people in. We're going to get started in about 1 minute. But before we do that, I want to introduce Anna. I actually want Anna to introduce yourself. I know I introduced you, Anna, but would you take it from there?
Well, thank you, Jose, for this introduction. As Jose said, I'm a founder of Oncoscope AI, which is a human AI hybrid approach to providing a decision support tool to oncologists. And I am here to ask our four distinguished speakers who need no introductions at all to talk to them about their approach on how they use AI in their decisions about the treatments for their patients and what advice they can give to oncologists and researchers and other healthcare professionals on how to select the tool that you can trust. What are those secret ingredients that should be in that tool that would help you trust the tool more and help you save time instead of waste the time with that tool. And I think without further delay, I would love to start with our first speaker, and that Dr. Douglas Flora. And I am sure that those who sign up for the webinar do know him and have seen him talking about his patients and oncology, and sometimes how he talks about various AI tools that he's very excited about, and we all know, so he knows how to use those tools. Um, Doug, I'm going to base my questions on the various videos I've seen of you and the various talks you've done to ask you back some questions. You obviously have used various AI tools, and you talk about your knowledge on how to use the tools. But for some of us, and that, for physicians out there that may be novel users to those tools, how do you learn how to do the right prompts? And what is the secret to learning that? How do you avoid asking multiple questions? How do you get to the correct question? Is there a trick to avoid asking question after question after question from the AI tool to get to the right decision?
Thanks for having me. It's a deep question. Obviously, that's an hour in itself, but I'll give you the 2-minute answer. I think you have to get away from the idea that it's a search engine. This is a thinking assistant. I start every conversation with hi because it flips my mental frame into I'm having a conversation. And a lot of what I'm doing is verbal now. It's audio, and I'll be in my car and I'll say, I need you to build me an agent that will accomplish the following goals. I want it to be curating content from these 5 websites. I need us to be a professional thing along the lines of Medscape or OncLive or other. And then you get 65 pages of code in 6 minutes. And then that website or that agent comes out with a newsletter Monday morning at 7:30. So I think if people start to play with it, they'll be amazed. If you have a conversation with these things and you tell it what they want, what you want, you'll get the image you want, you'll get the video you want, you'll get the copy you want. And there's no magic to it. Now it's very little prompt engineering because the computers are smart enough that they build the prompt for you. All the stuff that we used to write with chain of thought reasoning has almost gone away, and almost all the hallucinations are going away with the newer models. So I think the best thing I could say is get in the sandbox, start playing, solve a problem, book a vacation, try and figure out how to get from point A to point B in the problem that you're trying to solve. And that's the first tool I refer to every time. And I've got about 5 of them in my phone now. I don't actually have to think anymore.
Wow, great. You've mentioned before in some of your talks that it is important for you to be able to check your work, check your work with references and with actual data. So do you believe that maybe a hybrid approach where you know that some humans already checked those answers, can that help you to trust the tool more?
Yeah, I think the two things that physicians in particular are going to demand of these tools is you need to have a human at the wheel, and that's right in the ASCO guidelines for any oncologist out there. You are responsible for the work that you put out there, and you can't sue Chat GPT for Omni. So we are ultimately responsible for our products and our decisions. So that's number one. Number two is as we are looking at these things, I think as healers there is still some intuition. There is still gestalt. There is still a general sense in doctors that we have a larger picture. And I'll use the example, my AI tools, and I tend to lean into Gemini a lot these days because the context window may give a decision, but it really can't build in the fact that I'm trying to get the patient to the daughter's wedding in June, right? And that's a nuanced thing. Or that this particular person is a network newscaster and she's afraid she's going to lose her job if she loses her hair. And so I might pick a non-traditional, non-guideline based treatment that any AI algorithm would never understand. But that's where we are the chef. We finish the meal, we taste the food. And I really don't want us to sacrifice that in the name of efficiencies or lowercase q quality. I think we should do both. Get the uppercase q quality, and then you have the maestro, the chef taste the food.
So would it be important for you to see the actual data presented in front of you, or would just the paragraph of text be sufficient? Would you want to click and be able to see the actual reference to the primary study and check it yourself? Or as a community oncologist, or as an oncologist that treats many, many, many cancers, do you even have time for that?
I fear that people will cut that corner, so I get an additional sense of reassurance knowing that some other human has already checked the work. And I will tell you, the guys on this call have used lots of Perplexity, I'm sure, and it is still rife with hallucinations for medical citations. It will cite them as securely as your overconfident intern who lies on rounds about having checked something. And then when you go to the citation, the journal doesn't even exist. I've seen myself quoted in papers that I've reviewed for my journal, AI and Precision Oncology, and papers cited with my name as the principal author that I never wrote. So that's very concerning to me. So yeah, I think a human needs to be at the wheel, and probably for the near foreseeable future.
Okay, and then another thing you just mentioned, you talked about potentially prescribing a therapy that is not even in the guidelines. So would you be looking for a tool then to provide you that very clear identification of what is in the guideline, as well as what is maybe has some positive result but is not yet in the guideline? Are you looking for both, and how important is that?
I think it's critical, especially second, third line. I have a patient coming in to see me urgently in 50 minutes, and she's going to fall between guidelines. I don't have any confidence in going through 128 pages of NCCN in 2025 is the best form of care for my patients anymore. So I'm looking to a lot of these tools to help me. Deep research functions for sure, tools like Oncoscope for sure, and others that I've found to be more reliable than a 3-month-old paper document that I used to go through page by page like the rest of you. And I think breast is up to 168 pages. I'm a breast doctor, and it's tough because I get to the end of page 168 and they give me 7 options. That's probably not where we're going in medicine in 2026, 2027.
So, considering you just mentioned several tools, in our very short conversation, we had less than 5 minutes, and you've mentioned several. Is there a rule you apply to what type of question you would use which tool? Or is that something you would like to, because potentially you are obviously using multiple tools for different types of question. Is there kind of a rule you will apply to that?
Yeah, I won't use anything that doesn't give me a citation that I can check. So I love hyperlinks. So if you can direct me to the 3 papers that explained what you just told me about, I check the links. And I have built some pretty extensive prompts for myself on some of the models that I have sort of bastardized that myself because they didn't previously exist. And that's what I've been using for about the last year and a half. So I'm actually really glad to see some of these more validated models. And I've encouraged you and some of your colleagues that I want to publish this stuff in our peer-reviewed journal so that people can understand explainable AI and adding the step of the human at the wheel. I think it's a really important step, and I think that it's inherent upon us to be responsible introducers of this. And if you're on this call and if you're watching this, you're probably in that 2.5% early adopters. So it's up to us to get it right before the masses discover it in 18 months. And so I'm taking that charge pretty seriously. And that's what I'm writing about is the responsible introduction to these tools.
Thank you. This is really helpful, and this is a great opening to our discussion. I am going to now move to Dr. Stefan Gluck, who has a bit of a different perspective because he only treats breast cancer. So you would assume he knows everything there is to know about the breast cancer. He sleeps and dreams with breast cancer, and still in my last conversation with you, Stefan, you said, well, there's too much information coming down the pipe. So as the specialist in one cancer, considering the recent science, as someone who attends ASCO and all the major conferences, what are the sources you personally use? How do you keep up to date with all of that? And if you were to use an AI tool, what sources does it need to cover?
Yeah, so thanks for having me here. And yes, in my private clinic for many decades, actually, I have been treating through two different universities. Last one was University of Miami, breast cancer only. In a public hospital, obviously, we do everything, hem-onc. But my focus and my research is in breast cancer. So when I was heading the program at the University of Miami, I was basically known as the encyclopedia for breast cancer. Somebody asked me questions. I knew the paper, I knew the citation, I knew the page where the survivor curves were. Now, in the meanwhile, things changed drastically. And at the last ASCO, those of you either were there or looked at the presidential address, it was stated every 26 minutes, sorry, seconds, there is a new paper in medicine, new manuscript published in medicine, which translates into 5,000 papers per day. And about 10% of those, 500, will be in oncology. So how ever can a person read or be even aware of, even read the titles, not the manuscript, not the abstract, just the title? You can't. And that's where I think AI comes in to help. And I repeat what actually Doug said, help. It will not replace. So there's a quote which I slightly am changing. AI will not replace doctors, but doctors who use AI will replace doctors who do not use AI. And it's coming. And Doug, you're right. We are here the early adopters. Some of them are the leaders. And there will be another couple of years until more people are doing it. In other words, if you have the right tool to answer the question that you are posing, you are asking, what is out there in third line metastatic, in my case, or Doug mentioned it also, breast cancer. And then I will an answer within seconds, maybe half a minute, and it's okay. In the last week, last month, last year, there was 170 papers. Tell me what you want to know. And this is how we will very precisely get an answer. You and I, we will make the decision how to treat the patient, not the AI. They give us recommendations. They give us the papers. They give us the guideline. They give us the clinical trials opportunities. But I make the decision together after explain it to the patient with her or him. There's 0.7% breast cancer males. So that's where we are, and that's how I see it. It's a very important, necessary, and unavoidable tool that we need to curate. A second thing is, and you mentioned it in the beginning, Oncoscope is a hybrid thing, which means we have somebody, a person, a human, who makes sure that the information is not something out there, but makes total sense, is published in a peer-reviewed, highly profiled, referenced journal, is included in some of the most important guidelines for us, ASCO, NCCN, for Europe, ESMO, and so on and so forth. And as you may know, there's about 1,500 guidelines in medicine and about 250 in oncology worldwide. So it's not so easy to know everything. You can't. A person cannot. And I stop here.
Right. So just to emphasize that, sometimes these tools, the AI chatbots may provide you a reference. As Doug said, it's important to have a reference. He loves the links, to click on the links. But how important it is that when you click on that link, it is actually a primary reference and not maybe another review paper or, I'm sorry to say, Wikipedia. It could be, or I'm not even going to cover when the paper doesn't exist, but I'm talking how important it is that there is a human behind that checks and to make sure that it cuts through the noise and you only get the papers that are robust. How important is that to you in your work?
Extremely important, because if something happens like to my question, there will be 5 or even 50, or let's say something in the middle, 15 references. I do not want to click on 15 references. I want to click on 1, maximum 2 that I know they are the correct ones. So the curation, the choice, the human selection to do the right thing will be for me important. And how do I know? Well, I need to trust. I need to trust this tool, which is combined AI with human curation, human decisions. And I can only trust it after I've seen a number of examples, maybe 5 examples, maybe 50. And over time, as we're using a tool, we trust it more and more. And now and then, those who are critical, like we all here are, we will double check. Is it really still the best answer, or can I just use something else and find something different? So you double, triple check, and then you become confident that you are choosing the right thing.
Okay, and an interesting question, again, connecting what Doug said to what you said. Sometimes there is nothing that you could prescribe for the patient, or you're looking for something that is not necessarily approved or indicated. And you are looking for something that may be off-label or in the clinical trial. So would it be important for you to have it within the same structure, within the same tool? Because there's a lot of tools right now which are really great at what they call connecting patients to the clinical trials. But what I see is missing sometimes is looking at the early evidence, maybe in phase 1 in something, okay, it's not approved, but you're looking at the data first and then searching for the trial for the same drug. Talk a little bit about that. How is that process work for you? How would you make a decision to sign to try to look for a clinical trial for a patient? What is the process there? What are the steps?
Yeah, so there are actually a number of questions you ask in your couple of sentences. So the most important one, the first one is off-label using. So off-label use happens if a drug is confirmed or approved for, let's say, lung cancer, and I know from phase 1 or phase 2 studies, smaller studies, 50 patients, there's a signal in breast cancer. So I would like to use it in breast cancer. Obviously, I will get a big pushback from the insurance. So I need some evidence to prevent the pushback or push back the pushback and say, yes, I know it's off label, but it's already approved for lung cancer. And I have 2 or 3 papers indicating that in breast cancer it might help. Sometimes NCCN does it and NCCN might help, but sometimes it does not. So yes, I would like to have this opportunity by, for example, Oncoscope doing exactly what you just said. The second question you are asking is about clinical trials. Now, clinical trials are a 2-way street, actually 3 ways. Find the right trial to my or your patient, or the other way around, find the right patient to their trial. And then, of course, we as a middleman, if I may say so, who makes it possible and chooses for the patient, you know what, yes, you would match this trial, but for such and such and such reason, I do not think it's good. Or for such and such and such reason, I think it's very good for you because everything what's available so far will be available even after the trial, but not when you skip the trial. So you have one more step in between where you can do exactly what Doug said. That is a typical thing for a practicing oncologist. I want my patients, even if she has incurable and late stage metastatic breast cancer, to have an event done right in June. I think you said June next year, because the disease-free survival is the important thing. Overall survival, maybe she survives, but she needs to be disease-free and enjoy that event.
Thank
So
you.
I need the choice on the clinical trials both ways.
Okay, I'm going to move on to our next speaker now, Sorin, and I'm gonna change the questions a little bit because Sorin, you are a professor at an academic hospital,
Yes.
and you are responsible for raising the next generation of oncologists who are going to treat us. So I see that you are spending, I met you at a continuing education event, and I know you are lecturing a lot, you are teaching, and that's one, at least one of your passions besides treating patients, of course. So how do you see AI helping with that education of the new generation? Is there a role for these tools to help with that education? Because as you know, the young students, they don't know, they're not like Stefan, they just need to know the new. They need to know the new and the old and everything together. And there's quite a bit. So talk to us about that.
Yeah, thank you, Anna. Thank you for having me here. Very important question. And as Douglas and Stefan both mentioned, early adopters. Yes, there's early adopters on this call. There's early adopters in an audience, but really our trainees are some of the earliest adopters of anything AI or technology related. We're seeing this from medical students up through fellows. They are utilizing any and all AI resources in whatever ways will help them become more efficient, whether it's in the clinic helping with note writing, whether it's note taking when seeing patients in the clinic setting, or for helping to craft their presentations. And so what we're seeing is they are looking for any models that'll help them broaden their knowledge base, right? And so where I see AI fitting in is rather than them going to the old textbooks, the Harrisons and the MD Anderson textbooks to look at what is, how do you work up colon cancer? What are the next steps? They're using AI to kind of craft out an outline for them. And, the resources that were mentioned, ASCO guidelines, NCCN, they have all that in there, but it is a bit cumbersome to have to click through each specific type of cancer, each subset, each stage. And so AI tools can help collate all of that into a algorithm that the fellow or resident can then utilize to kind of create a framework in their minds as to how a certain cancer type is worked up. Secondly, in terms of staying up to date on the latest research, as Stefan mentioned, there is just so much data coming out, so many trials resulting, so many newer drug indications across oncology that now is a time that it's a very exciting time to be an oncologist, but it's a very daunting time to be an oncology trainee to try to keep up with that. And so that's where those AI tools come into play in terms of reviewing, say in the last 3 years, what have been the highest impact studies that have come out of lung cancer. That's how they can kind of stay abreast of that.
So how important it is, you believe, that these tools based their outputs on a systematic review of the evidence to provide you kind of a comprehensive picture versus what most chatbots do, which is providing you one-off kind of answer or may not be a complete answer. How do you feel about that? Is that important?
Yeah, I believe it's very important, especially from a trainee's perspective, as they're trying to, create their foundational knowledge, right? They need to have understood all the data and evidence that's brought, that's kind of laid the groundwork for what we currently do in our clinical practice, and then build on that to integrate all the newer things that are coming. And so an AI tool that integrates guideline-driven data, that looks at what are long-established kind of pathways would be more meaningful, as you mentioned, than kind of asking a tool that gives a one-off, well, here's this phase 2 study that we saw for XYZ. That may not be more meaningful.
Do you believe there is a potential role of AI in CME? Because there's so many meetings every week. I see on LinkedIn there's announcements, at least 4 meetings going in parallel, and so oncologists have a lot of opportunities to attend these amazing all day long, 2 days, the weekend, spend the weekend and learn what was best at ASCO. In case they missed the ASCO, they have best of ASCO, they've been told. So is that sufficient? And do you think AI still can help in some way? And what would that be? What would be the imaginary magic tool that helps with that?
I think an AI tool can help play a role if it's curating the CME program or helping to curate with that human component on the content or the program. So for example, I do primarily GI cancers. If I wanted to give an update talk on colon cancer updates for the last year, right? I could utilize an AI tool similar to Oncoscope, where I could query, what has been the latest updates from GI ASCO, General ASCO, ESMO GI in metastatic colon cancer. And if that tool can help outline all that, then that can help me craft a more efficient and more effective presentation.
Okay, and as an oncologist who has to do, I've heard, recertification all the time, how do you feel about using chatbots to help you answer, or maybe not you, maybe you don't need a chatbot, okay, on your side. But I meet a lot of doctors who come in and said, I'll use the chatbot. It's really great to helping me answer that, because I've had talks then with nurses and with patients, and some of them said, oh my God, I am horrified if my doctor is using that. But can you help us relieve our anxiety with that we don't have a chatbot doctor, what is the role here that maybe I can play to help with this recertification or initial certification?
Sure. So, the certification process has changed over time. At least now for oncology, it's no longer a necessity to take that 10-year recertification exam. You can do ongoing certification over a 5-year period where you answer a number of questions every quarter. That format allows you to utilize any resources that you would like, right? And so you have access to up-to-date NCCN, whatever it may be. The web is kind of open for you to answer that question within that time limit. And so it offers some flexibility for the test taker to maybe use those resources to kind of confirm what they already suspected. However, I do not feel confident yet to query a chat bot and simply ask, here's my prompt, here's my question, what do you think the answer is? Especially because those answers may not come verified. There may not be any data behind it. As Douglas mentioned, there may not be a reference to what it is recommending. And when you're going for recertification and have to pass this exam or this exam format in a certain amount of time over a certain time period, it probably isn't worth the risk of doing that. And then at the end of your 5-year period, realizing, well, I didn't get enough questions right. So the resources such as UpToDate, guidelines that are human created and human verified, I think at this point, from a education standpoint, are more valid and maybe more effective than simply asking a chatbot for a response.
Well, thank you again for that. With this, I am moving to our last speaker, and then this would allow us to then ask everybody follow-up questions, because I am dying to ask whether the Doug has very special prompts that ensures that someone can pass their recertification in a fly. Okay, a magic, how to do that. But I would like to get to Jacob. Jacob, I love your posts on LinkedIn because I always read them, and I've told you I read them and I said, I should have said that. That's exactly what I was thinking. I just can't put this on paper. So you often give us guidelines or guidance in a simple way on how should we assess an AI use in medicine. So thinking specifically of decision support tools, is there a simple, more or less, checklist that
Yeah.
a physician may use to say, is this a reliable tool or is this not? We've heard a lot, but I love how that's why you're last, okay? Because you can give us this amazing bullet points on kind of that discussion. What are the important points?
Thanks so much for the question, Anna, and thank you to be on this esteemed panel with amazing experts in the field and to be able to speak on this. We as clinicians right now are bombarded with AI tools, which is a good thing. It's a good problem, but we need to evaluate them there, not from a technical lens, but from a clinical one. So tools will look good on slides, but maybe they're not working in our real care settings. Solutions are not aligned with the clinical priorities. I have worn many hats over my career. I'm a clinician. I worked in the emergency departments, and now I've transitioned into digital health. And I have seen, and I'm a health tech founder working in consultancy and policy as well. All of those hats, I've realized there's a gap, and there's no consistent way for us as clinicians to ask, does this tool help me? Is it safe? Can I trust it? Because we talk about model architecture, but not about our usability or context. So I put together some things for myself that I thought, okay, this will help me go through it. And especially it's important for CDSS, clinical decision support systems like Oncoscope AI. The core principle I would say is you start with the clinic, not with the code. So Anna, you have done amazing work with Oncoscope AI, and that brings me to the first point. Is this solving a real clinical problem? Is this something that we spoke about? Like now, many of these expert oncologists have come on and they have spoken about pain points that they face in their day-to-day practice. Whether you're a community oncologist, where you're an academic oncologist, is this solving a real issue? Okay, who is the user that this is designed for? Is it designed for the oncologist, for junior staff, researchers? If we see a mismatch between tool and user, this will lead to failure. Many tools put on the label of AI, but what exactly does the AI do? We as clinicians, we may have, had a basic understanding, but that is transitioning very fast into understanding that not all AI is the same. There are tools that do very advanced understanding and comprehension, and then there are tools which are just simple rule-based aspects. So what exactly does the AI tool? In this case, is it summarizing evidence, suggesting treatments, or is it just retrieving literature and helping us filter it? A key aspect that I look at, and that is key in any aspect, is the data provenance. Where is the knowledge coming from? Can I see what was searched, what was included, excluded? This ties in very clearly with the ethical AI aspects, or XAI, when we're talking about explainable AI, transparency, because all of these ideas built together builds trust. And another key thing is the human oversight. There are different ways of saying it. One of the speakers said human at the wheel. We hear this in different ways: human-centered AI, human in the loop. In this case, within the WMA, we're looking at the term clinician in the loop. Oncologists in the loop, in your case, in the CDSS, who are those people? What are they doing? Human-centered AI improves safety and trust because we, over the decades that we have built modern medicine, the specialties that we talk about, including oncology, it is not built willy-nilly. It has been built upon the foundation of trust, one step, one brick at a time. Does it fit into the actual practice? No tools float outside. Can I override outputs, ethical guidelines? And then I'm quickly talking about the next steps. Afterwards, once you've deployed the tool, are we monitoring it? What are the measures for success? So all of these, there's so much. I could go on for a couple of hours explaining this checklist because it's important, but at least we can have a systematic way to review something and say, hey, can I use this in my practice? Can I recommend this to my fellow clinicians? And can I use this, most importantly, to help me treat my patients?
Tell us when we're going to see the checklist published. Soon,
In
right?
process.
In process. Okay. And another question, which is kind of hypothetical at this point. We've talked about chatbots, and then we've talked about kind of a living decision support based on human input and SLR. And each of them, though, have its own place. You know, I have heard you talk about that the currently, why is there an attraction to chatbots despite the fact that we know they're potentially not the ultimate decision support at the end, maybe not references. Can you talk a little bit about, though, what if, do you believe there is a universe in which maybe those two would merge together, and what would that look like? What would that ideal tool look like that would have maybe a chatbot and maybe also have a human in the loop, a futuristic look at this? What is that?
Great. I love those questions. I love thinking about this because it's so important for us to understand where we are now and where we want to be. Very simply, from my understanding, chatbots have been developed, and why they have taken on a mainstream, application and excitement. Why people use is very simply, it's built on how we communicate right now. Every one of us has FaceTime, has iMessage, has WhatsApp on our phones, and we're using that. We're talking, we're chatting with one another. Translated that into ChatGPT and other LLMs. That's how we're interacting, and that's how we're getting information. Tie that into medical chat bots or medical LLMs that are being used. The information, so say I'm chatting with you as an oncologist specialist, the information I know then comes through that filter. So there will already be filters in place that says, okay, I'm chatting with a chatbot that has XYZ things, and that's tying in with the prompts where we put prompt role prompting. We ask it to reply in different ways. So you're going to see that very specialized aspect of, I need you to serve as a chatbot right now. I need you to serve me a specific function, which is I need evidence that I can use to practice right now, say in breast cancer or whichever it may be. And in that, automatically the chatbot puts its filters in, puts its roles, and gives you the output. Do you like long answers? No. If you don't, it'll give it in bullet points. So the adaptability right now, which I've already built into the way I put my profiling into ChatGPT, it answers in a very specific way that I need. So personalized responses will be very key. Not every oncologist here is the same. They take information a bit differently. Maybe some like the long articles, maybe like some need the articles, the first bullet points, high level. We can see that adaptation come into it. And then, as we say, human-centered, at this stage right now, which is so key, and I completely agree with one of the speakers said before, which is why it is essential that all of us as clinicians, beyond just oncologists, demand that these tools have that human-centeredness right now, because not just because of the fancy things that are being involved or being scared for our future. No, it's about making sure we build trustworthy tools that will help us, because we know the revolution is happening right now and we will embrace it, but within the guidelines. So talking about the future, I see tools that have been very much validated and reviewed with outputs in the same way and personalized for use for Doug as the oncologist, for Dr. Stefan as the oncologist, for Dr. Soren, specifically personalized in the way that they need it. And then there will be other aspects as well.
That's amazing. I'm glad this is being recorded because I'm going to take detailed notes later on. And one day we will all repeat this webinar I don't even think couple of years from now. And maybe we're all going to look back and said, look, and now we have that. Well, thank you. Thank you very much for this. We are going to go on now with a short demo. I'm going to show everybody the Oncoscope. What is this? The tool for those who haven't seen that. I hope I can share my desktop. You let me know if that's okay.
It's working.
Say yes, it's working. And I'm just going to do a short demo, and then we're going to open it to discussion, really about the further questions and follow on. So an oncoscope is an ongoing daily conducted systematic literature review. When you log into a specific cancer. I'm going to show you the breast cancer, and then you select patient's characteristic parameters such as, disease stage, HER2 status, biomarker. Let's say I'm selecting a potential risk if there is any, and then I come to a treatment path. Am I selecting if I'm in metastatic HER2 negative, which is what I selected now? You will see the treatment path is built in front of you, which is consistent what you would see in the guideline, except instead of being across 250 PDF pages, it's on one page and it is interactive for you. And then what you see here is, let's select first line. What is here is the treatments in black that are recommended by the guidelines, and also treatments in this green color, which we call Oncoscope Radar, which is from the clinical trials that have shown in pivotal stage positive results, but have not yet been added to the guideline. There's also other evidence, which is potentially early evidence or offline evidence that, Stefan talked about. Let me select for example, CDK4/6 inhibitor, because this is a traditional standard of care, most recommended care in HER2 negative metastatic. There is still 40 studies. So what do you have to do? And if you click, you see that several CDK4/6 inhibitors are recommended in the guideline, and several of them are category 1. So what do you do? How do you select? And as Doug and Stefan mentioned, side effect profile is very important. You want to see the data. Show me the data. So you click explore the results, and at this point, it's pulling these studies from the database. And you will see the studies in front of you. These are organized very similar to PubMed, so no training required. And as you could see, every study is tagged, whether it is in the various USA guidelines, in the ASCO guideline, and these are linked. So if you want the FDA package insert, it is linked. If it is the registration in clinicaltrials.gov is linked. Also, the abstract is linked. If the data, as you see, the biggest difference for PubMed, the data has already been extracted for you. And if you want to see other data, you can add your response rates, quality of life, even subgroup data, everything in front of you, and it is already extracted. It will be added here. Another little trick here is, if there's more than one publication, like in this case, you could click on more publications, and it saves you time instead of figuring out, okay, which one is the primary publications, which was the early maybe interim analysis, and which maybe been later for a subgroup. So this saves you time to know all of the publications are grouped together. What though, if you are Stefan or someone like him, who, like he said, a walking encyclopedia of breast cancer, and he doesn't need to see a study from 2024, he's already known about it, but he does want to know what's happened in the last month. So you could sort this by most recent studies. And what you see here, just July 25th, there was a publication of an early evidence. Right away, you see it was early, and this was just the phase 1 study. So again, you can click and read that publication or you can just see the data, the top line data that has been already extracted. That is basically all the tool. I've managed to do it in 3 minutes. I'm very proud of myself. Okay, I've practiced to go short and not to go around, because I wanted to leave us time to actually talk again to our speakers, because really all of you here are to talk to the speakers. And I want to bring in Jessica Regge, who is Oncoscope's Chief Medical Officer, to help us. She's been processing all of your questions in the meantime and figuring out what is she going to ask. And I'm going to give the mic to her and let her ask our speakers follow-up questions.
Thanks, Anna, and thanks everyone for the great insights you had. I'll start with you, Jacob, with a question. I'll give you a little bit of premises. In your wonderful checklist, I got data is central and human at the steering wheel is really important. And we talked a lot about those humans being you guys, the oncologists, right? Treating the physician. But what about humans ensuring that the right data is present within these databases? So can you talk a little bit? Is a human person having advanced degrees important to be able to ensure that you have the right data?
Jessica, thank you for asking one of the key questions, because when we say AI, there is no discussion about AI without talking about data. Data provenance is key. And so there's two options that we have, and we have to be realistic. The first option is wait for a perfect data set, fully representative, clean, global, having all of the necessary things that are built in. I'll be honest, that doesn't exist. We inherently, unfortunately, have our inherent biases as people that is built in and that comes in. The second option is using existing data sets, but building the trustworthy systems on top of them, which is where we as humans come in. Because we know no data set is truly bias free. The risk isn't the bias, it's the invisibility of bias. So this is where humans should be asking. Who is underrepresented? What settings are absent? Are we talking about, is this been from just an academic setting, or has this been used in rural LMIC? What about specific ethnic groups? Be honest about these gaps up front. And then flagging the uncertainty. If a model hasn't seen enough data for a certain group, say so. This builds in confidence levels, and they add disclaimers. We can stress test, even with small sample sizes, measure performance where it matters. Don't just report, average AUCs, show the stratified results. So where we talk about human in the loop review, we're looking at this, we're saying, okay, are there version controls happening? Audited trails. Do we as physicians have the right to override? Say an output comes in and we say, no, I don't want this for XYZ. Can I report that back? Is there an escalation process? So we don't need perfect data. Not that we don't need perfect data, we don't exist in a world with perfect data, but what we need is transparent models with the clinical oversight and the humility to say, here's where the tool is working and here's where we're still learning. And this is why we cannot go away from human-centered AI right now. We need those guidelines and those boundaries right now so that we ensure the safety for what we deliver to our patients, and that we can stand on what we're saying there.
No, thanks. And I think, when we look at all of these, I think we really need to be looking at the data and the sources. And that kind of leads me to my next question. So Douglas, I'm going to put you on the spot. You talked about using AI to book a trip, and really just getting in and getting some experiences behind AI. Now, I'm sure you've used the tool that Anna just demonstrate, Oncoscope AI, and or even other tools. But can you tell us, other than a decision support tool to help you pick a therapy for your patient, what are other ways you can use Oncoscope AI's tool that you see, maybe beyond just that decision support tool for your patients?
I assume you mean beyond completing my MOC questions for my board certification?
Yeah, anything. Could you use it for a, a board certification?
Of course you can. Of course you can.
Yeah.
And the danger for Oncoscope for a board question is probably the board questions are out to date, and you and your team have loaded things Friday night at 8 o'clock that will not be represented in the board scores. So that's a little dangerous with the newer models. As they get more and more up to date, they're ahead of the question writers because the data changed in June in Chicago. In serious note, I think that the things I was alluding to, the 168 pages of breast stuff, and Stefan and I are both breast doctors. I find that unwieldy. I find it outdated. And so when I see tools like this, where the references are available and it's 2 clicks away from me actually getting to the paper that I'm supposed to read, I think it elevates our game. And I will say I'm as guilty as anyone as a busy person, and I'm only in clinic 1 day a week these days because I'm a pseudo doctor now that I'm an administrator. A lot of my medical knowledge is now coming from the ASCO Post or the ASCO Daily News or the things that are getting mailed to me because it's available and I open it on the table in my kitchen as I crack my first beer or I pour my first wine on a Friday night. And that's not how I used to learn. I used to really sit down and study exclusion inclusion criteria. And I feel like since these tools have made that more accessible to me, I'm moving back to the good side of being a good doctor. And I'm reviewing these things more critically. So I will say, as editor in chief of a journal, been really impressed with the quality of the tools that I'm able to review. I get to read about 40 manuscripts a month for peer review, and the tools are getting there. They really are. And I credit you guys for the work you've done. When I lecture nationally, I'll often say start with simple things: rev cycle management, coding, prior authorization, physician documentation. And I say stall a little bit because we're not quite there for clinical decision support 2027 version. What you guys have done, I think, is really nice is that you've hybridized it. You've taken the human at the wheel that we've talked about, and you've given a very vast, up-to-date data set, to the day. That is the closest thing I've found to that so far. And we are looking. My journal is looking. We may do a review article on these tools. We've talked to a couple potential authors that I've reached out to say, can you summarize where we are in applications of tools for clinical decision support? Because it's something everybody's asking. I will tell you, in the clinics, my doctors are not quite ready yet until we get some of this stuff published.
Yeah, no, and I love to hear that, you're using your experience in your forum, particularly the journal forum, to help further educate others. Because I mean, I think all of us need to lean into AI, but we also need people like you to help us figure out what's the best out there. So, kudos to you. So, I'll pivot and ask Soren a question. When we talk about Oncoscope AI, and we talked a little bit about the data and the utility behind all the data, what goes into when you're thinking about putting a patient on a clinical trial and or maybe considering an off-label use of a drug? Is there something within this tool or something within AI that you could use to help you with that?
Yeah. No, that's an excellent question, and it speaks to kind of the notion of clinical trial matching, right? Finding the right trial for the right patient at the right time. So the trouble without having AI is the resources to look up clinical trials right now are very arcane. Clinicaltrials.gov is the largest database, but it's very slow to be updated. It's often hard to tell whether trials are actually open or not, or even recruiting. Secondly, it's proximity. So unless you are in a practice that engages in trials where you can bring those trials to your patients, or you're in an area that you could refer close by to a larger medical center, whatever it may be, outside of that, oftentimes it's hard to get patients to a center to be able to get the studies. So given those two, I would think major limitations, I think where AI could come into play and where a tool such as Oncoscope could come into play is it could help identify maybe more effectively what studies are more appropriate for that specific patient population. Now, specifically using Oncoscope, if you were to put in, as Anna kind of demonstrated, that you're looking for a specific subset of patients, right? Not just breast cancer metastatic, but those triple negative who are now on second line who have this mutation. And if that tool can identify, hey, there actually is a trial specifically for this patient population, then you've saved yourself a lot of time and research and avoiding a database that isn't the most up to date and found a potential answer for your patients. Now, some of that is actually being done by NGS companies right now. So companies such as Tempest Foundation, et cetera,
Yep.
they are connecting to, unfortunately, the clinicaltrials.gov database. And so when you get an NGS report, you also get a list of studies that could potentially work for it. However, the limitation there is the data that's utilizing. But, and I say this because I also consult with some of these companies. They're trying to be more proactive where they're utilizing AI to identify patients in trials up to the moment, like in that moment that, okay, you have this patient, he had an FGFR mutation, and we now have this study that just opened at this center for this, versus trying to look back at a larger database. So I think the opportunity is there. I think there's still a lot of legwork, though, into making it more effective and not simply regurgitating what's already in databases that are available.
Yeah, no. And I'll save my last question for you, Stefan. I guess, where do you see, when you look at all of the guidelines out there, right? Because there's not just US guidelines, but there's international guidelines. Do you find this to be a potential tool that can help you kind of navigate through those quicker? And how much time do you think it saves you?
Yeah, I think that's a very important question because as we practice in the US, we are focusing on US guidelines. Number one, for me at least, the most is NCCN, and the close second is ASTO. But there are many others like ASH guideline and so on and so forth. And sometimes you are not sure whether you agree with the guideline, and then it's a good thing to compare. What would a European do? What would be somebody in my native Germany do, or my favorite country in Italy do? Would they do the same treatment in second line? And you know what? Yes and no. It's not quite the same. That's why we have so many guidelines. They are not identical. They are similar. So this is one thing that I need guidance from the AI, and I will ask questions the AI to lead me through. And what was said many times now by all four of us, we need to have it published in a reputable journal, peer-reviewed journal, high IF, impact factor, preferably randomized phase 3 studies, but also some other studies that I can trust have been acquired in an appropriate way, with all the GCP, Helsinki, and blah, blah, blah. So these are all things that I think AI can help us, because otherwise, painfully slowly, I would need to do it online myself. Impossible in today's world.
Yeah, no, thanks. Anna, there was one question in the chat, and I think you're the perfect person to be able to answer this. Why are we unable to access the full journal articles?
We cannot access full journal articles because that would not be legal, because then we would break the author's agreement and we would not be able to offer this tool for free to everybody. I do know that Open Evidence, for example, does access the full text of certain journals that they formed an agreement, but then they only share it with physicians that have an NPI number. So there's no pharmacists, no nurses, no, you can't just log in, or international physicians, if you don't have an NPI. So I have conducted a test personally. I just letting you know, I looked at 1,000 papers in breast cancer, and I wanted to know, based on the abstracts, what information would be missing from the abstracts. And I could tell you, I know exactly what information is missing. A lot of patients' characteristics and subgroup data. That is what missing. Patients' characteristics, subgroup data, and one more, detailed quality of life analyses. The truth is that no response, PFS, OS results are going to be missing. Everything that is primary. And the truth is, we wanted to create a tool that doesn't substitute you ever going to the original paper. I'm sorry to say that. It helps you to find the original paper fast and to find the relevant paper fast. And you would know if OS or PFS is reported. We have not created a tool that helps you not to read the paper, okay? You do have a link to the paper. We are speaking currently with several academic institutions where we would link this tool to their library. They have licenses to library, and then we creating custom, but this is one institution at a time. And if you happen to be the lucky person who works for that institution, you will soon be able to have a tool that gives you access to full text as well, and it is a seamless way. But it is not a technical issue. It is a legal issue right now, which, by the way, we do hope to be resolved on a level much with much bigger companies than us, as OpenAI is in this litigations right now, and I hope not to be involved in those litigations.
Yeah. No, thanks.
Yeah.
We're going to start the after party soon.
Yes.
Do you guys want to wrap up and thank the audience? By the way, I want to thank all the speakers. Anna, do you want to start wrapping up the event?
Well, I just want to thank everybody because I think it was the most exciting discussion, and I think it's a needed discussion. And I do hope that our listeners and those who will watch the webinar would get some points on and get more excited, and we get more early adopters of wanting to try the AI. And I hope I may say that they can reach to these speakers. You're all findable people, easy to find on, and to get some further pointers on, and we are all waiting for those papers from Doug that he promised he will publish to tell us which tools are great, and the paper from Jacob, who's going to tell us what is the checklist. So we thank you again for that.
And we're going to start the after party in about 1 minute's time. And we're saying goodbye to YouTube. This is where we clip the webinar for the recording. Thank you very much, everybody. If you want to stay for the after party, please do so. We're bringing people on to the to speak on camera. Thank you very much, everybody.
Thank you.
And it's going to take a couple. It's going to take about 1 minute for people to come on. Are all the is everyone staying for the after party on the panel?
I can stay 10 minutes.
I have a patient outside of my door right now. I do have to step away, but thank everybody. This was good. Really good.
Yeah. Thank you so much for your time.
You bet. Okay.
Thank you, Dr. Flora. And while we're getting people coming on, it takes them a minute. Can I ask a question? Oh, we've got people coming. We've got a couple of questions from the audience that we didn't address. Sandra Warren, maybe this is for you, Jessica. As we continue to explore the role of AI in oncology, I'm curious about how it's currently being integrated into clinical research, from protocol design to patient recruitment and outcome prediction. What are some of the most promising ways AI is being used to accelerate cancer trials? And can we ensure these innovations translate into equitable and effective treatment options for patients? Is that something you can speak to, Jessica?
Yeah, no, I think, yeah, I think we hit on a couple of those aspects through the various discussion points, but yeah, beyond having tools that will, if you ask it a question, let's say within a chat bot, or even as Anna showed with Oncoscope AI, where you can actually go through a treatment pathway. I think there's other ways we can use AI that we talked about, right? We could use it to identify clinical trials that are potentially out there, and where those trial sites are for those potential patients. And I'm sure some of our even panelists might use AI for that if they have a very particular patient with a particular, as we talked about, biomarker, like with the foundation panels, and it says you have an FGF mutation, and here's these 5 studies that are out there. Then they can go use AI to see what centers maybe have those trials. So we touched on some of those aspects. I don't know if anybody else has anything to add, but I think identifying potential trials, identifying where those trial sites are, and then identifying any new data associated with those trials. Maybe the phase 1 data is published, but the phase 2 is the trial that you're sending them to.
All right. And I have another question. How do you see AI helping to bridge gaps in clinical trial diversity and patient access, especially in oncology studies where representation and recruitment continue to be major challenges?
Yeah. May I?
Go ahead.
So we know that in the United States, about or less than 4, I repeat, 4% of our patients are on clinical trials. And representation from some variety of ethnicities and minorities is even worse. I will not single out others, but we at the Miami, we have, published a number of manuscripts, not only which ones are underrepresented, but why. And I think we have been pretty unsuccessful to overcome this problem. I see a huge opportunity now. AI can help to overcome this because you can say this patient, if I can identify the patient without the name, and so being completely HIPAA compliant, obviously, and of course, I can identify the patient and AI tells me there's 5 different trials across this country and another 2 in, let's say, England or I don't know where. And then I can choose and I can bring it to the patient quickly rather than spending half an hour on clinicaltrials.gov, which was mentioned, or the patient spending 2 hours and coming with a printout of 17 pages. So I think this is a big opportunity.
We've got do you mind if we take some questions? Do you mind if I put a few more questions? We've had some questions in the Q&A.
Jose, can I just add to a bit
Go
to that?
ahead.
Yeah, sorry. Yeah, so thanks so much, Dr. Gluck, for what you've mentioned. I just want to add, so basically along the same lines, but 3 ways AI can help, especially when we're talking about the gaps in trial diversity. So gap identification. So AI can analyze EHR, registry, demographic data, so identify which groups are underrepresented in trials. Number 2 is smarter patient matching. So we look at NLP or natural language processing plus structured data, matching the diverse patients to relevant trials. So moving beyond narrow inclusion filters and manual screening. And number 3 is decentralized trials. With AI, we can support remote consent, monitoring, follow-up. So we reduce travel time barriers for those who cannot access this and for these underserved populations. So this is the, it can close this trial diversity gap, but only if we build it to recognize who's missing and not just who's convenient.
That's an excellent point.
I'm typing it an answer, and I would like to answer it in to everybody instead of typing it because I'm not very good at typing. I'm reading. There is a question.
I have one more short comment for the trials, and I mentioned it in a very early discussion. We can also match the other way around, not the patient to the trial to the patient. So if I want to do it, this will be probably a big opportunity to find other trials, as you said, geographically or ethnically or whatever the patient's problem may be, or just an access to and financially, which is another problem, and help. So I think, yeah, we do have an opportunity to get help from here.
Okay. We have time for another question.
I'm reading. Jose, can you unmute me as I'm not
You are.
muted? So
We can hear you.
I read a question in your Q&A. How does Oncoscope AI compare to open evidence? As a matter of fact, we've just submitted an abstract to San Antonio Breast Cancer Symposium together with, and Stefan is one of the authors on that, where we've asked 8 clinically relevant questions in breast cancer to both tools and some other tools. And by the way, Doug is also one of the authors on that. And so I could answer based on the research we have conducted using the specific questions. So the difference is that open evidence searches New England Journal of Medicine and JAMA, and that is the scope and some related journals to JAMA, which are, of course, really, really great medical journals. However, the answers that for the questions we asked, what we saw is the answers were sometimes not up to date because there was a lot of evidence presented, for example, at different and recent ASCO, as well as, there were medical approvals, there was changes in the guidelines. These were not incorporated. So the answers did not include the recent developments that could help the patients. Because of that, also the evidence, the answers were incomplete. I know that Jacob talked one time, I heard him talk about the criteria, accuracy and completeness. And in oncology, an incomplete answer is just something we cannot accept ethically. It's unethical to not have all the choices for the physician to choose from. So as an example, we asked one of the questions and it gave us, instead of 3 drugs that are currently even approved and in the guideline, only gave us 1. Okay, so it's not wrong. It was an approved treatment, but it didn't give us the other 2. And another thing which is consistent across all chatbots reference everything. They find one reference to answer their question, whatever is on top, and they give you that reference. And it is almost in 100% of cases a review, an editorial, someone's opinion, or whatever was the most recent that's written about it. It's very, very seldom a primary reference of a clinical trial. And finally, chatbots do not provide you data, extracted data in a data table that you could check. And you heard Doug say he wants to check his answers. He wants to see that. So you're kind of on your own. Even if a trial would be mentioned, such and such trial reported positive data, you would see no data. And there's no reference to that trial that you can click to find it. But the answers themselves are mostly correct. They are not, you can't say they're wrong. Okay, so if you are asking a specific question, for example, does this and this drug cause nausea? You would get a very quick and great answer, But if you're asking what are the therapeutic choices for patients with such and such mutation who failed on these therapies, you may not get a complete answer supported by the most recent references that you could check yourself.
Liam, you're free to speak.
Sure. Can you hear me?
Yes.
Yeah.
Yeah. First, I wanted to thank you, Anna, and everyone on your panel. I know a couple of you through the LinkedIn. It's been a great discussion, and it's a nice tool. This is my first session. I just wanted to get myself familiar with what Oncoscope can offer. My question is, I just want to make sure I understand. So can we ask question like how we ask question from the chatbot through the Oncoscope? And if not, how can we, I personally think that can be useful in a limited time of the clinic, just have it as an option. And why it's not something that you think might be helpful or may not be appropriate for that?
I can answer very quickly. Why? Because we're a company of 12, soon to be 15 people, and we haven't gotten to that. We just launched at ASCO.
Okay.
That is a very, I agree with you. I 100% want to do that. And we are working on that. But so far we released 1.0 at ASCO, then 1.1, 1.2, then iPad version. We're going at a speed. I'm working 7 days a week with Jessica, but can't get to everything. Sorry.
Right.
Congratulations. You're doing great.
We will be there. We will be there. Just not yet.
Yeah.
So many congratulations.
Thanks. And to Anna's note, what we're trying to do is get all the tumors out, and then we're going to add hopefully additional enhancements, such as what we just talked about, because we believe it's important to have as many tumors out there to help you guys first.
Yeah.
And since I got this chance to talk, I agree with Stefan. I think it would be nice to have some sort of peer-reviewed, top journals, or let's say 20, 30, how many it can be, just to have the search first, maybe based on that. And if someone wants a more depth or, more like a rare cases, looking into the second series of the database. I'm sure you guys are thinking about it this way too.
We definitely, we want to make sure though that we cover the potential resources that guidelines are using, because we are cross-referencing with several guidelines. And right now we're in the process of incorporating European guidelines, which is yet another. But we want to make sure if they may use that publication as a reference, then we should also have that. So this is extremely important.
We have another question. Might have missed it, but what is Oncoscope's business model?
Everybody wants to know, how are we going to spend money? Okay, I'm going to have to give you some bio. Okay, I'm a healthcare economist. I had 25 years in pharma, and then I had a boutique company in health economics, which I sold, lucky for me, for good money. And then I have decided to spend my money to change the world. And I know these are big words, but that's the truth. I have several friends that are suffering from advanced cancer. And what I see is that sometimes their physicians are not prescribing to them what is most recent or what is even in the guideline. And it hurts me. And I started with, I would say, trying to inform one doctor at a time. And then I realized I'm not going to get very far with that. And what if I create a tool? And yes, we are giving the tool for free to all the physicians out there, physicians, nurses, pharmacists, any healthcare professional that is involved in patient care. If you're a consultant on the call, or if you're a pharma, you can reach out to me. There is a version that is for the money. You're asking me for the paid tool. Also, we have received a lot of comments from academic doctors and academic institutions to try to incorporate other ways to search, not one patient at a time, but more for a research projects. For example, what's new in PIK3 mutation, and seeing wider aspects to help to produce a report for a prior authorization. We are about to release, stay tuned any day now, a new version that is called Edge, because it's for those of you who are on the edge. And yes, that would be a paid upgrade. So if you want more out of the tool, it will be a paid version. And that is my business model, that I hope that, that would be the model I'm following.
Jacob, you had a question.
Not a question. I just wanted to say thanks. I have to sign off. But
Yeah.
I wanted to thank you so much for organizing this, Anna, for having me on along with the other panelists. Just want to say, it's amazing what you, Anna, Jessica, the Oncoscope team are building, especially as a founders in health technology, to build with purpose, with humility, with the idea to solve a real pain point. And this is the way that we build a future for AI. So kudos to you all, and thank you for having me.
Thank
Thank
you.
And I can only
Thanks.
echo. This is fantastic, and agree with you, Echo. Sorry, I have to also sign off, as I mentioned. I'm already a bit later, but
Thank you.
fantastic. Congratulations.
Thank you very much.
Thank you. Well, Anna, we've answered all the questions.
Great.
So
Everybody can reach me in any way. They know how to find me. And
always leave when you're still having fun.
yes,
Yep.
thank you, Surin. Thank you very
Yeah.
much.
Thank you
also
so
for-
much.
Nope, happy to be
Thank
here.
you.
Thank you all.
Take
All
care,
right.
everybody. Have a great
Bye.
day. Bye.